Welcome to POCUS Geek. In this video, we're going to review normal anatomy for the most part of the gallbladder and the scanning technique which I teach to my residents and staff for looking at the gallbladder in order to not miss anything. If you haven't had a chance, I would recommend looking at the pathophysiology lecture in which we talk about how this develops. I think that helps you understand and better perform this study when you focus on what you need to with imaging the gallbladder. So, indications. I'd say most of the time we're looking at the gallbladder with right upper quadrant pain when they present to us. There are other times that we'll see things and should consider that. I think one time that we don't think of it a lot is in patients that are older with sepsis, that we don't find a source. I think we need to look at the abdomen for causes of sepsis. And in elderly, the gallbladder can be a common cause of sepsis in these patients. As always, I like to talk about the binary questions, and these are the yes/no questions that we like to define. And some of these do require measurements, and these, in conjunction with the clinical picture, can help us determine if a patient has cholecystitis or make that diagnosis. Remember that ultrasound is not the ultimate diagnosis of cholecystitis, but it is a data point or provides information that can support a diagnosis of cholecystitis. However, it is a clinical diagnosis, but we can use some of these sonographic findings to help us diagnose it. So what we're going to look at is the binary questions. Is there a sonographic Murphy sign? What this means is that when you image the gallbladder and you get over that gallbladder fundus, you apply pressure with the probe at that spot, and that should be their point of maximal pain. Are there gallstones present? If they have a sonographic Murphy's and there's gallstones present, it has a high sensitivity for cholecystitis. It is not very specific, but it does have a high sensitivity. Now, this is what I think is the most important part of this study. When looking at cholecystitis, not cholangitis or not choledocholithiasis, but just cholecystitis, is there a stone stuck in the gallbladder neck? If there is a stone stuck in the gallbladder neck and the rest of these signs are not present, the patient has persistent pain, you should either watch them and perform a scan in several hours, or have good follow-up for them, or talk with your surgeons. Because inevitably, if there is an impacted stone in the gallbladder neck, they will develop cholecystitis, or they are in the process of developing cholecystitis. After that, then you'll typically see, so then our next question is there thickened anterior gallbladder wall? Subsequent to that is there pericholecystic fluid? And then we do look at the common bile duct to see if it's dilated, which we can find with choledocholithiasis and cholangitis. You can have a stone stuck in the gallbladder neck that puts pressure on the common bile duct and will dilate the common intrahepatic duct. So that's also an area that we're looking when we define it as common bile duct. You want to use a low frequency probe. You can use a curvilinear, more commonly known as a abdominal probe to many, or a phased array or cardiac probe. If you're using the phased array probe, make sure you're in an abdominal setting, and actually in either probe. That will have your settings for the machine set up correctly so that you can best image the gallbladder. Gives you a better frame rate, better image quality. So make sure you choose that abdominal preset. I follow a specific sequence every time I image the gallbladder, and we're going to go through that sequence. I like to start with the probe marker towards the head, right in the midline, as we see here. So I will start with my probe right here, with the probe towards the head. And then I like to sweep along the costal margin, and I'm paying attention not only to the gallbladder, but also to the liver, and looking for any abnormalities that I may see. Even though it's not one of our binary questions, we are always trying to identify any abnormality, whether we can diagnose it with certainty or not, but we should be able to recognize something out of the normal and be able to move to that next study that should better define that. And so I like to bring with the probe along the costal margin towards the patient's right, towards the mid-axillary line, and look at the liver, the gallbladder, and all those structures as I pass through there, make sure that they all have the same echogenicity that they should, that there's no masses, no hypoechoic lesions or hyperechoic lesions. That also lets me know how easy it's going to be to look at the gallbladder. If I can't see that way I will turn the probe marker towards the patient's right. So go like this. And then I'll do that same sweep with the probe marker towards the right, fanning up under the ribs, trying to visualize the gallbladder. If that's not possible to see it that way, I usually start in a supine position, but if I can't see it that way, I'll have the patient roll to their left into a left lateral decube and try that again. If that doesn't work, you're going to start looking through the ribs right here. There's a spot right there to look. That gets pretty difficult, so unless you've done this a lot, you may want to have a consultative ultrasound at that point, or look at other imaging modalities. But that can occur if you develop that skill. Another technique you can use is you can roll them to the right lateral decube and try that. I don't have as much success with that, but I know people that do perform it that way. I know some people in radiology suites, you can have beds that they can lay prone and you can reach around them and scan. If you're in an emergency department or your clinic, you could have them kneel down on their knees with their hands on the bed and also look that way. But typically, I'll just try the supine left lateral decube, and then I'll look through the ribs if I need to. So it's hard to define the anatomy well here, and the reason why is because the gallbladder is a mobile structure. It's only tethered at the gallbladder neck, so this anatomy can change a little bit, but we will see some of these structures come in. So I've tried to define those here for you. We'll see them in the next image, but we're going to be looking at the liver and the gallbladder. After I've done that sweep through the gallbladder, or through the liver, and that right upper quadrant, then what I do is I always look for the gallbladder in a long axis first. That helps me see the course of the gallbladder, if it's folded over upon itself, and best define its anatomy. So what we're going to see here is our gallbladder here in red. Go with yellow. Here's our liver. We can identify that structure up there. We do see in this image, you don't often see it, I'm going to do it in green, is the kidney. And it's right there. And then we have some vessels. Let's do those in blue. Right here and right there. That's going to be your IVC and aorta. Now, like I said, this is not what you're going to see every time. This just happened to be in this image, and I did a drawing of that to show you one example. Here's another example of how the gallbladder can lay. We can see over here on this side that the gallbladder is extending off of the screen. We ideally would like to see that in there. I imagine during this study that was imaged, and we would like to see that. However, we are able to see the gallbladder come down like this and come up here. Sometimes it can be hard to image it in a single image. We can use video if that's what you like to do. I like to use still images, but you can do video. We can see the long axis of the gallbladder here. And what we're gonna be doing is looking for stones. I'm gonna back up one image here. We're gonna be looking for stones to lay right along the back wall here. And we'll look for shadowing of those. So once we've looked at the gallbladder and evaluated for stones, again, probably the most important part of this is looking at the gallbladder neck. So if we look here, we want to get down to this portion. And the gallbladder neck will typically be pointed or directed towards the portal triad, or at least it will approximate it. It doesn't always point right at it, but it will approximate it. And we should see these structures. We can see what's called the Mickey Mouse sign if you look at it here, being the portal vein, common bile duct, and the hepatic artery. Some people like to look for the common bile duct in that view. We'll talk more about that later. But what we're going to focus on right now is the gallbladder neck. Now, in this example of this image, our gallbladder neck is actually tucked back under. And what we have is, the gallbladder neck comes right like that and up this way. And so this area right here is our gallbladder neck, and we really want to make sure if we see any stones in that area, because that's going to be, if a stone's impacted there, that's going to eventually lead to cholecystitis. We're going to look at another example. So here's another example of the gallbladder neck, and what we notice here, I'm going to back up, sorry, is that these walls should taper, and they should always connect. So these walls taper, this wall tapers here, and they come together. Now, we do see a little bit of a hyperechoic structure right there, and that's the fold in the neck, and that's normal, but what we can see is that those walls taper towards each other, and they combine. Now, why we want to look is if there's a stone stuck in that neck, that's going to eventually lead to cholecystitis. So what we see here is we have stones here. Let me put those in, let's put those in purple for now. So there's stones up in the fundus, and here's a stone right here in the neck. We see shadowing and shadowing. And what we don't see when we looked at that compared to the others, we see this back wall, we follow that, and then it disappears to the stone. There's no taper like there was before in that last image. So let's come back out here. If we look at this tapers like we shown before. It comes here, we follow this posterior wall, comes down, meets the anterior wall. That tapers together, whereas when we look at this one, they don't. Let's get some of those structures off if we can. So you need to make sure you visualize the gallbladder neck in this long axis. It's much easier to see it in the long axis than the short, but you are going to then rotate the probe, and you want to look at the entire gallbladder in a short axis. So just to reiterate, we've looked at the gallbladder in a long axis. Well, first we started at looking at the entire right upper quadrant, sweeping through there. And then we're looking at the gallbladder in a long axis. And then we're going to look at the gallbladder neck in a long axis. Now with our probe rotated 90 degrees, and you'll notice that I've not talked about the probe being towards the head or towards the right. It doesn't matter. The gallbladder lays in a plane of its own. So whatever direction the probe marker needs to be for you to find the gallbladder in a long axis is how you're going to rotate the probe and find it. And then you'll rotate your probe 90 degrees to that. And then what you'll do is you're going to fan. I like to fan from the neck to the fundus. I find it easier to identify the structures that way because I've already seen the neck and I'm down there after I've looked at it in a long axis. So just like we showed in that little thing there, we're going to sweep through it, clear up to the fundus. Now we're going to see a video here, and what we see here initially is the portal vein. We see the neck come out of there. We see a stone there for a second with some posterior acoustic enhancement, but that's a gallbladder, entire gallbladder in the short axis. And here at the beginning, let's see if I can put some drawings on. Here at the beginning, right here, we're going to see that the neck comes out right from this portal vein area, right here. Oh, a little off to the side. So right there. Okay, and that's what we're going to look for when we first do this. Now, we can get that in a still image, and what we see is right here is the gallbladder neck, and it's right here. We're cutting in that short axis, as we can see in the image, but we're going to be looking for a stone, a hyperechoic lesion with shadowing behind it, which we do not see here, but we can see that neck in that short axis. Then as we fan towards the fundus, we're going to be looking for any stones, and we're going to finish that, go all the way to the end till the gallbladder disappears. And then we're going to come back and get the anterior gallbladder wall. We always want to measure at the anterior gallbladder wall, because the posterior wall will always look thick secondary to what's called posterior acoustic enhancement. And what happens with that is that we have something called attenuation, where the power or strength of the ultrasound wave or beam decreases through as it passes through the soft tissues. Since the gallbladder is filled with liquid material, it will not lose that strength, and so the back wall will return a large amount of signal back to the ultrasound probe and confuse you if you measure that area. You won't be able to see it well. So make sure you're measuring the anterior gallbladder wall. Now, one of our binary questions is it thick? There's some, depends on who you agree with. I use a 0.4 centimeters or 4 millimeters as my, below that is normal, and above that is pathological. I've seen other authors and textbooks use 3.5 millimeters as their cutoff, and I've seen as high as 5 millimeters. So I use 4, and then along with clinical suspicion, help aid in the diagnosis. But that can help me know if the gallbladder wall is thick. Now, as after we've looked and made that measurement, our last and final binary question is the common bile duct dilated? Now, we're not going to typically see a stone stuck in the common bile duct, but we can. But it's not very common that we see choledochal lithiasis with ultrasound, especially with point of care. Some of the machines we have aren't going to help us, and we don't have the time to search that entire system, but we are going to try to identify the common bile duct and see if it's normal appearing. Now, again, these structures can be a little bit different for us to see, but what we will typically see, and the way I like to look for it, is pro marker will typically be towards the patient's right, and I'll look for the portal vein, and then just superior to that or anterior to that, I'll look for the common bile duct. We won't typically see the artery in the same image, but there will be occasionally that you see it cut. Right here, you can see it cutting between the two. It is coursed along with them, and then it's cutting through them. That's a pretty classic view if you can find that. One thing to note here that I want you to pay attention to, especially as we look at the next image, is that the portal vein will have a hyperechoic wall, meaning bright white, and the IVC will not have a hyperechoic wall. It will essentially be liver, anechoic space, and then liver again, or other structure behind it. So that can help us identify the two. And the common bile duct will always be anterior to the portal vein. It will not be posterior, so do not confuse those structures. So from anterior to posterior, if we're seeing all three, will be the common bile duct, the portal vein, and then the IVC. So if we look at this image, we can see our portal vein. We'll do that in blue. Comes right here. And back this way. I'm going to take that off because that's not right on top of it. And then we can see our IVC down here. And then just anterior to the portal vein, we're going to measure the common bile duct. Now, I personally use the measurements of everybody gets 4 millimeters, and that's normal. And then you get 1 millimeter more per decade of life above the age of 40. So what that means is if somebody is 60 years old, normal for them may be 6 millimeters. If somebody's 80, it may be 8 millimeters. But anybody under the age of 40 should be 4 or less. Now, some others will say that simply a portal vein, a common bile duct of 1 centimeter is dilated. But I think that you'll miss a lot of choledochal lithiasis if you use that measurement. And so I personally look for 4 millimeters or above. Now, this will be the most difficult portion of this exam, and this can be often frustrating for novice scanners when it comes to the gallbladder. But make sure you find the portal vein, and then look for the common bile duct to be anterior to it. Here's another example. I'll let you look at that real quick and see if you can identify which structures are which before I put labels on them. What we see, anterior to posterior, remember anterior is at the top of the screen, and then posterior is towards the bottom because our probe is placed anterior. We can see the common bile duct, Here we can see that little structure of the hepatic artery right here, the portal vein, and then the IVC. And I discussed before, notice that here the portal vein is hyperechoic on both walls, and the IVC is not. Here's another example. I want to show you several because they're not easy. It's not always easy to identify. This is done with a phased array probe. As you notice, our resolution is probably not as good as with the curvilinear, but we do have it there. And what we see in this one is that our common bile duct is laying anterior to our portal vein. It's superior on the screen, but it's anterior in the patient. Some people that I've worked with through the years like to look for this Mickey Mouse sign that I showed you earlier, and they'll look for the common bile duct this way. Just note that the common bile duct is typically the structure further away from the gallbladder neck. And what we see here clinically is here's our neck we saw earlier. Here's the neck. Here's our portal vein right here, hepatic artery, and then over here is our common bile duct. We'll do that in green. You see that. So when we take that off, you can then, if you want to use color flow to help you diagnose what structures are what, then you can do that. And then you can measure this here. And we do inner wall to inner wall when we measure the common bile duct. And in this case, if this patient was 80, that may be normal. If they were younger than that, say they were in their 50s, this could be dilated for them. And you'd want to have, it would depend on your suspicion in the clinical picture. Even if you didn't see the stone again in the common bile duct, which we typically won't, this would be concerning for choledochal lithiasis, and they should have further imaging through an ERCP or an MRCP typically. So once again, just to finish up, we're going to sweep across the right upper quadrant, looking for any other structures there that seem abnormal. We're going to image the gallbladder in a long axis first, image the long axis gallbladder neck, the short axis gallbladder neck, scan through the gallbladder in a short axis, measure the anterior gallbladder wall, and then we're going to look for the common bile duct. If you have any questions, feel free to email me at pocusgeek@gmail.com or comment below. This is not an easy study to do, so don't get frustrated with it as you develop the skill, but it can be very clinically useful and can assist many of your patients. Once again, if you have any questions, feel free to comment below or email me.